I agree with both sides. I think there is growing evidence, but I also don't think there's much debate that surgical reconstruction is still the gold standard for common femoral artery interventions. These are my disclosures. So first of all, what is a common femoral endarterectomy? Well, the bottom line is it's a very elegant operation done through the groin through a small incision in which we expose the common femoral and its branches. And this is the type of plaque that we remove, often in one piece. So you can imagine the challenge when you're trying to debulk something of this magnitude. We sew on a patch to prevent restenosis, and typically don't need any anti-restenotic drug therapy for that. And a common femoral can be done through an incision as small as 3 centimeters, obliquely oriented in the groin, easily done under local and sedation for thin patients, with operative times that range from 1 to 3 hours, with length of stay of only a day or so. What is a common femoral endarterectomy not? It is not a surgical bypass where we make these long incisions in the legs with significant morbidity, incisions over a distal target in the foot where we have ischemic regions of the leg, a recovery period of up to 6 months, like some surgical bypass or other major operations. So this is not what an endarterectomy is, and I think we need to consider that when we're talking about open versus endo. So whenever we're making that determination between open surgery and an endovascular procedure, we really have to look at the magnitude of the operation and how good the operation is and how effective it is. And the truth is, common femoral endarterectomy is simply a good operation. It has minimal morbidity, rapid recovery, and excellent long-term durability. Now, when we think about percutaneous treatment of the common femoral, this is where we see a lot of challenges. Common femoral plaque burden, as you saw from those images, it's bulky, it's heavily calcified, and it's coral reef in nature, which makes us very prone to embolization when we're trying to debulk it. None of our devices we have currently really can debulk this adequately, or at least to the degree that an endarterectomy can do. Stents across inguinal ligament, while there are some better stents for handling this, like Supera, these are often a problem when it comes to stent fractures. And the truth is, intervention often threatens the profunda rather than improving it like endarterectomy does. Finally, with percutaneous interventions, we really only have short-term data, and that's one of the big problems. So I also don't always practice what I preach. Just to show you, this is a patient of mine with an access site problem, mostly an intimal disruption, treated with atherectomy and DCB. As an outpatient, went home that same afternoon, and you can see we can get good results. But my discussion with this patient informed her that this is not the gold standard, and this is something we're going to have to watch closely as time goes on for restenosis. So what is the data pertaining to percutaneous intervention and endarterectomy? Well, it's not, there aren't any good randomized trials for this. There's a few. Mostly there are series and reports that look at one type of procedure or the other, and I'm going to go over that data briefly. When we look at the percutaneous intervention data, I will tell you that the bulk of this data shows that the patency at 1 year is less than 90%, and the bulk of the data is less than 2 or 3 years of follow-up. And so that's a big difference from the open literature. In this relatively early report of 360 interventions, we see that, yes, there's a low complication rate, some technical failures, but overall it's pretty successful, but a restenosis rate at 12 months of 27%, so nowhere near the 90% patencies we see with surgery. In this retrospective analysis of 167 patients, we see a common theme that PTA plus atherectomy or adding atherectomy helps compared to PTA, and stenting patients does better than not stenting them or using PTA. But even in this series, 20% restenosis overall through the series. This theme is highlighted in Lawrence Garcia's review of this recently. He looked at endovascular treatment options through a number of papers, 21 studies, and there's 2 themes you can see. So DCB or PTA alone without debulking or a stent typically has patency rates as low as 60% in the first year, whereas stenting or atherectomy or combination therapy generally raises its primary patency to the 80% range, 80 to 90% range, but it really, again, is only at 1 year, and there's very limited long-term data. So to summarize endovascular treatment, I think we have low morbidity. That's certainly true. PTA does appear inferior to atherectomy or stents. And the problem is that most of these studies show very short follow-up, and even during that short follow-up, we typically see loss of patency in about 25 to 30% of our patients. So what about endarterectomy? In this study of 65 limbs, we see, yes, there are slightly higher rates of complications, but they're not extraordinarily high, certainly not compared to surgical bypass. And primary patency at 1 year, 93%, and this is sustained all the way out to 5 years with 91% primary patency. In this large series of 713 limbs, we again see two main themes. Long-term follow-up, in this case out to 7 years with 59-month mean follow-up, and very high 97% primary patency sustained all the way to 80% at 7 years. Again, same sort of findings. This study of 118 limbs published in Circulation has, again, 5-year follow-up, so much longer than we see with percutaneous interventions, and primary patency of 100% in claudicants, 95% in CLI patients. Nothing like what you see with the percutaneous literature. So the series in the literature would suggest for common femoral endarterectomy, we do have slightly higher complication rates, but these are mostly minor and non-operative. Studies tend to have much longer follow-up than endovascular papers, and the primary patency rates at 1 year are in the 95 to 100% range, with sustained patency all the way out in the long term. So what about direct head-to-head comparisons? This retrospective study showed that compared 64 endarterectomies to angioplasty alone, showed that endarterectomy provides better primary patency without an increase in complication rates, 97%, 94% 1 and 2 year primary patency for surgery, compared to 75 and 57% for angioplasty alone. We talked briefly already heard about the randomized study. So this randomized study of surgery versus a bioresorbable scaffold showed superior primary patency with endarterectomy, 100% versus 80% at 2 years. And then the trial by Dr. Gufik that Stephen mentioned showed basically the main finding of this study was that there was a higher rate of morbidity for endarterectomy at 26%. No difference in these two outcomes, but even the authors admit in their conclusion that the study was limited by the fact that it's incompletely or inadequately powered to make any distinction about patency at 2 years. This is the most recent meta-analysis looking at all of these studies, and this really highlights the key points. Yes, we have a slightly higher rate of wound infection, but really not a higher rate of minor complications overall with endarterectomy. But for that cost, we get a much higher primary patency at 1 year of 96% compared to the pooled analysis primary patency for endovascular therapy of 78%. So I'd say that surgical reconstruction is still the gold standard for common femoral endarterectomy, for common femoral disease, because the data supports a higher primary patency for endarterectomy even in the early term results, and no studies really follow percutaneous intervention beyond 5 years, whereas endarterectomy's durability is well maintained over many years post-procedurally in the current literature. So I think that the morbidity and the mortality of endarterectomy is not nearly as onerous as surgical bypass or other major operations, so we should be very hesitant to abandon this great operation in favor of using the next shiny thing that comes along that someone thinks is appropriate for the SFA.